We're going to begin with a very simple question of what is personalized medicine, and really how does this impact patients in general? Is a personalized approach possible for all malignancies? And we're going to begin with Fortunato Ciardiello.
Thank you for giving me the opportunity to be here on behalf of ESMO. Within ESMO, I am in the executive board, and actually I was serving from the scientific committee as press officer in this congress, and so we will have a lot of other opportunities to meet also with the press on these topics. But the reason I'm here is that ESMO recently started a stronger and more effective program for directing or redirecting all our activities in terms of science, in terms of education, in terms of collaboration with patients and with patients advocacy groups on personalization of medicine in cancer. You know, this is a term that can mean everything or nothing, and so let's try to explain you what we think as medical oncologists is personalized medicine. First of all, personalized medicine is not that we do whatever we want to do to any single patient. It's still based on the same evidence-based medicine approach that makes effective treatments becoming the standard or the state of art. So it comes from the research efforts and extraordinary results that we had in the past 20 to 30 years to understanding the complexity of cancer, not only in different tumor types and organs, but also within any tumor. There is so much heterogeneity that, as you know, standard therapies that are based the same kind of therapy to the same patients just because they are arising from the same organ, let's say breast, colon, lung, prostate, whatever, is an approach that is active on the average, but it is not an approach that always works with everyone, unfortunately, as you know. And so we have reached, as we say, a plateau with chemotherapy, with radiation therapy on the general population. What we have learned in the past 5 to 10 years is that we said we can stratify within a given tumor different groups of patients and disease settings in which some molecular aspects, some biomarkers, some genetic alteration or protein expression are different. But this is not yet personalization of medicine. Just to say that if a patient has a given molecular alteration, I think about HER2 gene amplification and overexpression in breast cancer, we have identified a subgroup that is stratified for this biomarker, and we have effective therapies that can be started to be used, and this is the case with trastuzumab and other anti-HER2 therapies. This is just step one in the search of personalized medicine. Now with the whole genome mutation and expression analysis, with a lot of more technologies that are available, we can go even deeper in defining, for example, in the HER2 positive breast cancers, why, unfortunately, only 1/3 to half of the women with this alteration respond to anti-HER2 therapies, or why mechanisms of resistance to therapy. That is the only reason why anti-cancer drugs are very effective but fail for patient occur. And so personalization of medicine is to understand better the biology and the pathology of the tumor of any individual patient. So the key issue is going from an organ disease, breast cancer, to a stratified disease, HER2 positive, HER2 negative tumor, to an HER2 positive tumor in a patient with all these gene alteration characteristics that can help us to understand which is the most effective strategy of treatment if we have effective drugs for doing this. Of course, you understand that this is an evolution process. We don't have the solution in any cancer yet, but it's very important for patients and for patients' organizations and for the press that should help us to understand a few aspects. First of all, personalization requires humanization of medicine. You know, all these technologies have led to a less effective interaction face-to-face between patient and doctors. So it will be very odd, very strange. We are talking about knowing the 255 genes that are altered in that tumor, in that patient, maybe in a metastasis different from the primary tumor, and then we never see in the eyes our patient. So personalization starts with an individual relationship between the physician and the group of people that is taking care of the patient. To explain several things. First of all, that personalization requires a multidisciplinary approach. We need several experts because we need obviously the medical oncologist, obviously the surgeon and the radiation therapist, but the molecular pathologist should be part of the team in a more effective and integrated way than was before. We don't need to read only the path report. We need to interact with all the professionals in terms of medicine, in terms of nurses that are dealing with a single patient. This creates a lot of problems in terms of organization, in terms of costs, but it's the only way to bring effective knowledge on biology and pathology of tumors to an effective individual treatment in any single patient. This is our effort as ESMO to bring this to a wide knowledge in the general public, among medical oncologists, among the community of doctors involved in cancer. And the question was, is personalization of medicine in cancer possible in any tumor type? The answer could be easily yes, because any tumor type is heterogeneous, and in any tumor type we can find in a single individual patient the possibilities of exploiting this. But the path and the pace for reaching this is different tumor by tumor. And as I said before, the best cases are in breast cancer, but they are coming up also with other tumor types, with some leukemia, for example. You know that, I don't have to explain you. But another important issue with patients, with the patient advocacy groups, especially also for as a responsibility of physicians like we are and the press that is going to the lay man, the lay woman, is that if we want to have a real personalization of medicine, patients should understand that it's very important to be involved more actively in clinical trials. And clinical trials should be done more and more trying to make knowledge on the mechanisms, starting from early clinical trials. You know, the era of very large 5,000 patients, randomized phase 3 trials in which we try standard chemo plus or minus a new agent is ended, is not cost effective, is too expensive, and the results are very few. So we have to rethink, and it is also the interaction with the industries is very important, because every time a patient signs a consent to enter a clinical trial, this patient is very precious for himself or herself, of course, because he's trying to get something that is a better treatment, or at least a hope for treatment. But whatever comes from that, I will say, experiment in human beings should be useful for having more and more knowledge that can be used for other patients. And so tumor tissues, blood samples, all these issues of donating part of the body, I would say, like blood or serum or plasma or the tumor, is a very important issue, but should be used in a very careful way and should be used with the aim of doing all the clinical trials that are really aimed to personalization of treatment. And so now, this is a very long process that will involve us for so many years. Maybe when I will retire as a physician, we are still working on that because, you know, fighting cancer is not so easy. You know that when maybe 30 or 40 years ago, we were talking about not curable disease. We are working to cut out not from the definition of cancer, but personalization of medicine requires a lot of participation from the patients, a lot of awareness from patients of advocacy groups, and also a lot of pressing and pressure on the governing bodies and our authorities. Because at the beginning you can think personalization of medicine is expensive. It's the opposite. Personalization of medicine is try to do our best for that individual to get the best result for that individual. And the cost is something that comes after.